Welcome back to the deep dive. Today, our mission is tackling a really dense but super important area when the body's own protectors kind of turn rogue. We're digging into a medical surgical nursing chapter on excessive inflammation and overactive immunity, trying to pull out the most crucial stuff you really need to know.
That's the plan. We're looking at immunity and inflammation, the good guys usually, but we're focusing on when they go overboard, get too widespread, or, and this is key, start attacking our own healthy tissues. So the big concepts we'll be wrestling with are hypersensitivity, think allergies, and autoimmunity, where the body attacks itself.
Got it. And just to frame this for everyone listening, the chapter really zeroes in on how these processes impact patient care through two main concepts. Obviously, immunity and inflammation are the mechanisms, but the fallout, it often hits gas exchange hard in those sudden crises. And then there's the long-term damage to tissue integrity and chronic conditions. We need to keep those two sort of outcomes in mind.
Absolutely. Those are the clinical priorities.
Okay, let's kick off with hypersensitivity or allergy. This is basically the immune system overreacting to an antigen, something it's encountered before. It can range from, just annoying to actually life-threatening.
And we generally classify these reactions into four main types. It really depends on the timing and the specific immune pathway involved.
Type I is probably the most familiar one, right? The rapid or atopic reaction.
Yeah.
Why is IgE the big player here?
Well, IgE is kind of like the lookout. After your first exposure, these IgE antibodies get produced, and they stick themselves onto mast cells. They just sit there waiting. So when you encounter that allergen again, it binds to the IgE, and that triggers the mast cells to degranulate. They dump out a load of chemicals.
Including the famous one.
Histamine, yeah. That's the main culprit in the primary phase. It causes that immediate inflammation, the warmth, redness, swelling, pain, and loss of function.
Yeah.
Mostly by making capillaries leaky very fast.
Interesting point from the source material. The tendency towards allergies is genetic, right? But what about the specific allergy itself, like peanuts versus penicillin?
Yeah, that's a great distinction. The general predisposition, that ability to become allergic, that seems to run in families. But the specific thing you become allergic to, shellfish, pollen, whatever, that's not directly inherited.
Okay. Moving on to type 2, cytotoxic. Sounds pretty destructive.
It is. In this case, the body creates antibodies, autoantibodies really, that target your own cells. But only if those cells happen to have some kind of foreign protein attached to their surface. So the antibody locks on and essentially marks that healthy cell for destruction. The classic, really scary example is a hemolytic transfusion reaction getting the wrong blood type.
And the management there is pretty straightforward, if urgent.
Absolutely critical. Stop the offending agent immediately. So stop the transfusion. Sometimes plasmapheresis is used to try and remove those attacking antibodies from the blood.
Right. Then type 3, the immune complex reaction. You mentioned this is often behind chronic illnesses. Why is this one so different from that fast type I reaction? Why the persistent damage?
So here you get these clumps forming antigen plus antibody equals an immune complex, but you get too many of them or they aren't cleared properly. These complexes end up circulating in the blood, and then they just deposit. They get physically stuck, lodged in the walls of small blood vessels, especially in places like the kidneys, skin, joints.
And that's what causes the problem.
Yeah, that deposition triggers inflammation right there in the vessel wall, leading to damage. And because it's happening in tiny vessels all over, you get widespread chronic problems. Think systemic lupus erythematosus, SLE, or rheumatoid arthritis. That's often a type 3 mechanism.
Okay, finally, type 4, the delayed one. What makes this stand out?
The big difference here is it's not antibodies. No antibodies, no complement system involved like in the others. This one is all driven by T lymphocytes, or T cells. And because it involves T cells migrating to the site and then reacting, it's slow. It takes hours, sometimes days, to really develop after exposure.
So like contact dermatitis from poison ivy, or maybe a TB test.
Exactly. That positive PPD test for TB, where you get that hard bump, the induration appearing maybe 24 to 72 hours later, that's a classic type IV reaction.
And if it's delayed and T-cell driven, not histamine, what does that mean for treatment? Can we just give Benadryl?
Nope. And that's a really key point for practice. Standard antihistamines, those H1 blockers, they're generally not useful here because histamine isn't the main driver. You'd typically rely on corticosteroids to calm down that T-cell mediated inflammation and reduce the discomfort.
Okay, that makes sense. Let's shift gears now from the how to the, oh no, what do we do? We need to talk about two critical type I emergencies, angioedema and anaphylaxis. Because here, gas exchange suddenly becomes the absolute top priority.
Definitely. Angioedema is a really severe type I reaction, but the swelling is deep. It's in the blood vessels, the skin, the subcutaneous tissues, and critically, it often hits the lips, face, tongue, and especially the larynx. That deep swelling in the throat is what makes it such a huge airway risk.
Let's talk risk. The material highlights ACE inhibitors, common blood pressure meds, as a major risk factor for delayed angioedema. Why them specifically? And why delayed?
Yeah, this is super important because the mechanism is different. It's not primarily histamine causing this type of angioedema. It's another inflammatory mediator called bradykinin. Normally, the angiotensin-converting enzyme, ACE, breaks down bradykinin. But if you're taking an ACE inhibitor, well, you inhibit the breakdown.
So bradykinin levels go up.
Exactly. Bradykinin accumulates in the tissues, and that causes this deep, often slow-onset swelling. It can happen weeks, even months after starting the drug.
Wow. Okay, and we absolutely have to mention the cultural and safety consideration here. The sources are clear. Black adults, particularly African Americans, have a risk of ACE inhibitor-induced angioedema that's like 5 times higher than white patients.
It's a stark difference. The exact why is still being researched, probably genetic factors, but the clinical data is undeniable. It means we have to be extra cautious using these drugs in this population, and patient education on recognizing early symptoms is absolutely vital.
So when you're assessing someone who might have this, you can't wait around for lab results, right? What are the absolute signs for the airway?
You're looking for things like they can't swallow or they feel like there's a lump in their throat. But the most urgent sign is stridor, that high-pitched noise on breathing. That means the larynx is swelling shut.
And intervention.
Yeah.
Airway, airway, airway.
First step, always get oxygen on them. Give corticosteroids, give epinephrine. If the swelling is so bad you can't intubate, you need an emergency surgical airway, a tracheostomy. And crucially, it has to be placed below the level of the edema to actually bypass the blockage.
Okay. Now, anaphylaxis, the big one, the systemic meltdown.
Yeah, this is where all the blood vessels across the body vasodilate and the bronchiolar smooth muscle constricts all at once. It causes this massive drop in blood pressure, decreased cardiac output, and severe breathing difficulty very, very rapidly.
And the safety alert here is terrifyingly simple.
It is. The #1 factor in fatal outcomes is a delay in giving epinephrine. We just can't wait.
How do we diagnose it quickly, then? The criteria seem a bit complex.
There are 3 official criteria, yes, but clinically, you need to react fast. If you see rapid onset skin or mucosal issues like hives, flushing, swollen lips, PLUS, either respiratory distress or low blood pressure, that's likely anaphylaxis, or if they have 2 or more systems involved after exposure, you treat. Don't wait to tick all the boxes.
Okay, emergency nursing care, non-negotiable steps. Walk us through it.
Right. First, immediately check their breathing, airway, O2 sats, vital signs,
Yeah.
call for help, activate the rapid response team or code team, get back up.
Oxygen?
Absolutely. High flow, non-rebreather mask, aiming for 90 to 100% O2.
What if an IV drug is the cause? Pull the IV.
No. Stop the infusion, yes.
I agree.
But do not remove the IV access. You need that line. Change the cooping right away. Hang normal saline to keep it open. KVO.
And the #1 drug?
Epinephrine. Give it IM immediately. The eye is usually best. That's the first-line treatment. It counteracts the vasodilation and the bronchoconstriction. You might need to repeat it every 5 to 15 minutes.
Okay. And positioning? Head up or feet up?
Depends on the blood pressure. If they're severely hypotensive, get their feet and legs up. If their BP is okay-ish, elevate the head in the bed, maybe 45 degrees, helps with breathing.
Got it. And for patients at high risk, the ones who carry an EpiPen or an EAI, what's the absolute critical teaching point?
It's simple but vital. Use the device first, then call 911. Don't hesitate. Don't call for permission. If you think you're having a reaction, use it. Better safe than sorry. Time is absolutely critical.
Time is oxygen. Okay. Let's shift gears from those acute crises to the long, slow burn of autoimmunity. This is where the immune system loses its ability to recognize self. That self-tolerance fails. It leads to these chronic, progressive attacks on the body's own tissues. Currently, no cure.
That's right. And there's a huge genetic component. Twin studies really confirm this. And specific human leukocyte antigens, HLAs, are often associated with autoimmune diseases. And the gender difference can be, well, dramatic. Take systemic lupus erythematosus, SLE. It's roughly 10 times more common in women than men, especially during childbearing years. That strongly suggests hormones like estrogen might play a role in triggering it.
SLE is kind of the poster child for autoimmunity, isn't it? They call it the great imitator. Why is that?
Because the symptoms can be so varied and nonspecific, especially early on. Fatigue, joint pain, rashes, fevers. It can look like a lot of other things, making diagnosis tricky.
Pathophysiology-wise, it's essentially a chronic type 3 hypersensitivity, right? Those immune complexes again.
Exactly. Autoantibodies are formed, specifically against components of the cell nucleus, like DNA. These form immune complexes that then circulate and deposit in tissues all over the body. A major target is the blood vessels. You get this chronic inflammation of vessel walls called vasculitis. This impairs blood flow, reduces perfusion to organs over time.
Which explains why the big causes of death are often kidney failure, lupus nephritis, and cardiovascular problems. It's that long-term vascular damage.
Precisely. Diagnosis involves looking for a pattern, usually meeting 4 out of 11 specific criteria, plus supportive lab tests like anti-nuclear antibodies, ANAs. ANAs are sensitive. Most people with lupus have them, but they aren't specific. Other conditions can cause positive ANAs too.
And the classic physical signs we look for.
The most iconic is probably the butterfly rash, that red macular rash across the cheeks and the bridge of the nose. Also, profound photosensitivity. UV light is a major trigger, not just for skin rashes, but it can actually cause systemic flares of the disease.
So managing SLE is really about managing symptoms, trying to improve quality of life, and crucially, preventing organ damage. That chronic fatigue sounds debilitating, affects over 80% of patients. How do we help with that?
It's tough. A lot of it is lifestyle modification. Helping patients prioritize activities, what really needs to get done. Scheduling rest periods is essential. And maybe counterintuitively, encouraging low-impact aerobic exercise. Even when they feel exhausted, gentle movement can actually help build stamina over time, and definitely avoiding nicotine. For pain, things like moist heat can help joints, along with acetaminophen or NSAIDs.
And then there's the drug therapy to prevent organ failure. Corticosteroids are key, especially for flares, but they come with a host of side effects.
Oh, absolutely. Long-term steroid use leads to weight gain, that characteristic moon face, the buffalo hump on the back, fragile skin, osteoporosis, increased infection risk. Patients need extensive education and support around steroid use, including the importance of tapering the dose, never stopping abruptly.
Right, adrenal crisis risk. What about other drugs? The text mentions hydroxychloroquine.
Yes, Plaquenil. It's an antimalarial that also helps reduce UV light absorption, so it's good for the skin lesions and lupus. But big drug alert here, it carries a risk of retinal toxicity. This means patients absolutely must have frequent eye exams, usually every 6 months, including visual field testing. The damage can be irreversible, so monitoring is critical. That's a huge nursing responsibility.
Okay, critical point. And if the disease is severe, they might need stronger drugs, like immunosuppressants or cytotoxic agents.
Right. Drugs like methotrexate or azathioprine might be used to broadly dampen the immune system.
Which brings another major safety alert.
Yeah. These drugs significantly increase the risk of infection, not just new infections, but also reactivation of dormant ones, like TB. So the teaching is crucial. Patients need to practice social distancing, avoid crowds, meticulous hand hygiene, and report any sign of infection, fever, cough, sore throat immediately to their provider.
And going back to that photosensitivity.
Absolutely essential lifestyle advice. Avoid prolonged exposure to sunlight and UV lighting. Wear protective clothing, wide-brimmed hats, use high SPF sunscreen, SPF 30 or higher, consistently. UV exposure can trigger major flares affecting the whole body, not just the skin.
Okay, we have just a bit of time left. Let's quickly touch on Lyme disease. It causes chronic inflammation, but it's not quite autoimmunity, right?
Correct. Lyme is a bacterial infection caused by the Spirochaete Borrelia burgdorferi, transmitted by deer ticks. The immune system is involved, but the problem isn't really attacking self initially. The bacteria are clever. They use something called antigenic variation. Basically, they keep changing the proteins on their outer surface.
Like changing disguises.
Kind of, yeah. So the immune system mounts an attack, starts making antibodies, but then the bacteria changes its coat, and the antibodies don't work anymore. The immune system has to start all over again.
So it's this constant, ineffective immune response that causes the chronic inflammation and tissue integrity damage.
Exactly. That ongoing, but ultimately futile immune battle leads to the chronic symptoms affecting joints, arthritis, the nervous system, memory problems, fatigue, and sometimes the heart.
Early signs often include flu-like symptoms and maybe that characteristic erythema migrans, the bullseye rash, though not everyone gets the rash.
Right. Which makes early diagnosis tricky sometimes. Prevention is really key here. Avoiding tick-infested areas, wearing light-colored clothing, tucking pants into socks, using DEET repellent, and doing thorough tick checks after being outdoors.
Okay, this has been a really packed deep dive. We've covered a lot of ground, the 4 types of hypersensitivity, the critical differences in managing angioedema versus anaphylaxis, focusing on that immediate gas exchange need.
And then we dug into the complexities of autoimmunity with SLE,
Yeah.
hitting those key drug safety points, and the chronic management challenges focusing on tissue integrity. Plus that quick look at how Lyme mimics some of these issues.
We kept coming back to how understanding immunity and inflammation, especially when they go wrong, helps us protect gas exchange and tissue integrity.
Those core concepts really tie it all together.
So, thinking about practical application, here's something to chew on. We know that the biggest factor in someone dying from anaphylaxis is a delay in getting epinephrine, a known failure to rescue. So the question for you listening is, what concrete steps can you take right now in your clinical area on your unit to make absolutely sure that life-saving epinephrine is not just available, but immediately accessible and given without hesitation? How can you personally help eliminate that deadly factor of delay? Something to think about.